So what are temporary anchorage devices and when would you use them? So this is a patient who presents to our office. She's got a cant. So when we look at her smile, her quad 2, her upper left, sits higher. Look at the canine positions. So it sits higher than her upper right. This is 6 months. The TADs can actually move teeth quite quickly, relatively speaking. Now we're at refinement. So what do we do at refinement? We're going to start by talking about temporary anchorage devices, shortened to TADs. So what are temporary anchorage devices and when would you use them? So this is a patient who presents to our office. Some of you may have seen this case before, but many of you probably have not. This is just kind of like your level 1 of TADs. So what's going on here? Well, she comes in, she's got crowded teeth. That's her chief complaint. But she also says my smile doesn't look great, like she knows it's kind of crooked. We look at the teeth, pretty straightforward, right? You've got some basic crowding going on the lowers, same thing on the uppers. You could utilize optimized attachments here, so just Invisalign standard pre-canned attachments that come to you, or you can change the attachments, and that's what we'll do in this case, and I'll show you why and where. But the thing that she doesn't like is, or that she doesn't really, I guess, fully understand or know, is the fact that she's got a cant. So when we look at her smile, her quad 2, her upper left, sits higher. Look at the canine positions. So it sits higher than her upper right. These teeth have all super erupted. And likewise then, if you look at it from the front view, the lower right, premolars and molars also sit lower than the upper teeth. So essentially the upper maxillary right segment and the lower right mandibular segment all sit more inferior, right? Everything's come down. It's not just the upper teeth that need to move, it's also going to be lower teeth. What's interesting with this case is that this patient actually saw an orthodontist in our community, and that orthodontist talked to them about braces, first of all. They didn't even really mention much about Invisalign, but they did not mention at any point the fact that she had a cant or that this could be corrected. And so this patient, she recognizes something's wrong, and so she comes for a second opinion because she didn't feel like she got a comprehensive explanation. We explained to her that what we'd actually like to do, and I actually don't mince words here, I tell her, your smile right now has a problem, and what that problem is that your teeth in this section have all come further down than they should. You also have something else going on, which is that you have a hypermobile lip. It pulls up higher than it should. So using Botox and fillers can change the height of your lip, but it won't change the fact that you're showing more gums in the back than you really ideally would or should. What I actually want to do is I actually want to put a screw into your face. Like, I'll honestly sometimes just describe it like that to them. Like, I literally just want to go ahead and I want to put a screw into your face so that we can then go ahead and use elastics to pull up on it. And she goes, what? I say, it's not as bad as it sounds. And if you have a patient where you can clearly see this, she has piercings, right? And so I tell her, look, it's about the equivalent of getting a piercing. I do have to go ahead and place a screw into the bone, or I give you freezing first before we place the screw in the bone, but bone does not have nerve fibers. And so most patients that were gonna get this done are gonna say like, that was easier than taking out a baby tooth. But why we need to use this is because the braces or the Invisalign alone are not going to be strong enough so that we can actually push against those teeth and push them upright. So we have to use elastics to make that happen. Now, this isn't the case that I'm going to be showing you, but I will often then go ahead and show an example of a case for these patients. And anybody in Clearly Select has access to an entire comprehensive case library where I show cases like these that you can then show to your patients. So I'll go ahead and show this example. I'll pull up another patient who we've used TADs on. So I'll say, well, here's a patient. He's ground down his front teeth significantly. And so we put some freezing in the front section, or for the Americans on right now, numbing. So we numb it up, we freeze it up, whichever, and then we place these two screws. Goes between the roots. The biggest risk of having a TAD is that you're gonna lose the TAD. Right? TADs are not meant to be permanent. That's why they're called temporary. And so all we're gonna do, and I'll show you how we place them in just a moment, but we're gonna go ahead, we put a little bit of freezing in there, We literally screw it in like a drywall screw. Again, it's gonna feel like the equivalent of less than getting a baby teeth taken out or a piercing. But they're temporary, they can fall out, and you may find that happen. And it will fall out in about 25% of cases. So 1 out of 4 cases is gonna lose a tad, and we're either gonna have to place it somewhere else, or if it continually falls out, we may not have options for being able to keep using the TADs. The second risk is that it gets infected. Anytime you're cutting the skin or the tissue, there's a chance of infection. Now, what's gonna happen if it gets infected? Not a lot. Your TAD's just gonna get loose and you're gonna be like, hey, why'd this just fall out? It wiggled out. What's the big deal? That's about it. So that's my explanation. Nothing too crazy. So I'll go ahead and show her the reason why we had to do the TAD in this case is because we needed to intrude these front teeth. So we use the Invisalign aligners and we use elastics. We pull up on the teeth in order to level the gum lines. We're not actually again covering this particular case, but this is what things look like after the crowns are done. And so at the end of treatment, this is what it looks like after the restorative, whereas this is what it was like after the orthodontic treatment. This is what it looked like at the very beginning of treatment. So showing a tooth twin can be really, really helpful because they can see that it's been done on other people and that you're not their first ever case. Even if you are the first ever case, I would pull images of TADs showing cases that were completed to show these patients someone else who'd been treated with TADs, so they weren't thinking that that this was going to be the first time that that TADs had been used in this way. So I explain, of course, that this is something that's commonly done. So she now understands what a TAD is, why you might use it. We know there's basic crowding. We know that this TAD is super easy in terms of like, it's not trying to accomplish something that if we couldn't accomplish it, it's not like it's the end of the world. Because if it keeps falling out and there's problems with it, it's not fundamental to the success of this particular case. We could still go ahead and finish this case just fixing the crowding and the rotations if the TADs kept falling out for some reason. So that's kind of the ideal case to start with, right? It's not something where the TAD has to be successful for this case to work. So let's take a look at the ClinCheck. So here's what we received on our first ClinCheck from the technicians. There's a number of optimized attachments. So Invisalign's attachments, when you hover them, will say optimized, whereas a conventional attachment that you've made a choice to change, when you hover it, it's just going to tell you that it's a rectangle attachment. So that's how you can tell which attachments are present. Now, one thing that I will do on pretty much all of my ClinCheck plans is I will use a checklist. And this checklist is designed to help us walk through step by step all of the considerations with this particular case. Now, this particular one being a TAD case may have a few extra things that don't fall on that checklist, but for the most part, the goal is that you have something that you can review to make sure that everything was done properly. So the program that I use is called Text Expander. Again, anybody who's in our Clearly Select group has access to kind of the full range of templates. But inside these templates then, there is the Clearly Select templates. I have both now a basic one and a long one to really walk you through each individual thing. But you can see that we have a list of instructions that we're going to go through and see if we need to modify or adjust anything. So I can go ahead and type in now. I think it's CS-short-review. Review-CS-short. I have so many of these. And it's going to pop in then essentially a checklist of things that I want to review to see if they were done properly. So the first thing is kind of the basics. What did the technicians come back with in their comments? So they've told me here that optimized multi-plane attachments were used, and please review the current ClinCheck. That's it. Now, why this one might be important is sometimes the text comments will come back with, we couldn't place this attachment for some reason. Or another one was, there was a tooth that was virtually removed. This one was crazy. So last week I was reviewing a ClinCheck. The technicians took out a permanent canine tooth because it was so blocked out, and then they closed the space of moving the teeth directly into that canine tooth. Now they told us that in the comments, but the ClinCheck was worked up and designed without actually noticing that there was a missing canine, because that's the first thing to check. The next thing would be, is the bite set properly? So if we click to our records, we can now compare what does the occlusion look like from the side. Are the teeth in the same spot in the photos as what you see on the ClinCheck? Or is the patient biting with like a functional shift? Again, where this was relevant is the other day when I was checking one of my assistants' scan, you kind of see the classic, like it's brand new patient and the patient's biting right edge to edge. None of their back teeth are touching. If you take that ClinCheck and you use it, they're gonna set up the teeth with a ton of IPR on the lower, because they're saying, hey, they got this giant open bite in the back. Well, no, it's just my patient was shifting their jaw. And so when they're doing the scan, it's all in the wrong spot. In that case, because we caught it before the patient left, we just told the assistant rescan. But if you didn't catch that and the patient's ClinCheck was set up that way, but you look at the photos and you realize this is not the correct biting position here, then you could just tell the technician in the comments, you would just type in, please set the bite using the photos. Or please use the photos to set the bite, right? Like however you want to word that, reset the bite using the photos. Doctors ask me so frequently, like, how do I ask the technician this comment or this question or ask him to do something? And like the reality is there's so many different ways that you can word this to the technician. Just ask them like you were asking me. So that's why we're going through some of these very, very basic things in this checklist, because if you don't have the bite set properly, or if they virtually removed a tooth and then they're moving the other teeth into that tooth, what you're going to find is that your case is going to be set up improperly. You'll get through 5 designs of it, and then only when you're on the 6th ClinCheck will you realize that something was done horribly, horribly wrong. Or maybe the patient is in the chair and you're inserting these trays and now you're seeing that it's horribly wrong. So that's why it's just really important to have a sequence of steps that you go through every single time that never changes. And if you're in treatment with a patient, you can jump out, do the root canal, and when you come back, you know you start at the exact same position here of, yes, the bite was set properly. Now what we're looking at is, did they give us 4 passive aligners at the end of this batch of trays? So what does that mean? 4 passive aligners. Well, the last 4 trays, ideally, in all of our ClinChecks, we want them to set the plan up so that the last 4 trays are identical. They don't move the teeth at all. Well, that's not happening here, right? These teeth are absolutely moving right now. So that means that when the patient finishes treatment, at tray 40, she's gonna have to hold in that tray for potentially 4 weeks, 3 weeks, 5 weeks. What happens when she loses her tray and things start shifting and moving? Well, that's a problem. So we want to ensure 4 passive aligners. So I'm going to say here, give 4 nearly passive trays. I'll label that as 0.1 now, that I have to write to the technicians because that's not something I can adjust myself. Okay, next is going to be the bite position. Okay, so are we happy right now with the position of the teeth at the end of treatment? So the first question I'm asking, is this a growing patient? No, it's not a growing patient. If it's a growing patient, you always have to fix to class 1. But in this case, not a growing patient. So we don't have to fix to class 1, but do we want the patient to be in class 1 at the end? Well, yeah, absolutely, because she's in class 1 at the start of treatment. So it would naturally make sense that she should be in class 1 essentially at the end of treatment. Now we're maybe slightly class 2 on the right side here at the end of treatment, just ever so slightly. But all in all, I'd say that this patient's pretty close to class 1 on both sides. Not a lot of changes that need to happen. So we're happy. Nothing needs to change. Just delete the line and move on to the next thing. The next one was, if they're not growing, consider what's realistic. How much change can you make with elastics or anterior posterior adjustments? In this consideration, again, nothing needs to change because they're pretty much in the right spot. The next thing I'd look at is, are any unmovable teeth moving? So let's go ahead and take a look at our x-ray here. No implants, no crowns, nothing crazy going on. So there's no reason that anything can't move. So we don't need to lock any teeth. The next one would be, is the curve of SPE overtreated? So what does that mean? Well, the curve of SPE refers to essentially the incisal extrusion that occurs on the anterior teeth. So you can really see it from this angle. At the end of treatment, we want the teeth to sit nice and flat all the way across. But in this circumstance, these teeth are not. And so at the end of treatment, what it will often show is just the curve of SPE sitting flat. But sometimes we need to actually overtreat it. So in some circumstances, there actually has not been enough correction to flatten those teeth, which I think in this case, we could actually do a little bit more flattening of the teeth and leveling across. Maybe not as much from the patient's right side, but on this side here, I feel like the second premolar right now could definitely extrude a little bit, and the canine premolar and incisors could intrude. And maybe even the first molar could extrude a little bit too. So that's what we're referring to here with the curve of SPE leveling, and do we need to overtreat this? Okay, so I'm gonna leave this here because then I will come back and make that modification later. Okay, so what's next? Final arch form. Again, I'm kind of starting off by going through this checklist, and I'm just making notes of anything that needs to be adjusted or modified. And then once I click the modify button, that's when I can go in and actually start making changes to this plan manually. But to start with right now, I'm just kind of going through line by line until I get to that time that I'm going to make those changes myself. So are the upper first molars derotated in parallel? They're okay. They're not great. They're not terrible. But essentially, we just want to see if they're really, really rotated and more rhomboidal, we want to derotate them more. Do we have a nice arch form? So are the premolars and the molars uprighted? Like, do we have a nice shape to our arches? And we do. Again, I'm not going to go through every single detail and aspect in these cases because I want to focus a little bit more on the TADS part for you guys. But I also want to, again, not ignore the aligner side. So we do have a good arch form. Okay, smile, arc, and gingival display. How do we feel about that? That's a loaded question. So let's go to our photos. Here's our patient. So she's told us that she's not going to go ahead and do Botox or fillers right now. So we're going to have to work on this at the skeletal level of intruding those teeth. And again, this is the easiest TAD case to start with because the consequences of these teeth not intruding are not catastrophic. And it's only going to be 2 TADs that we're going to be placing on this patient. So what we really want to do is we want to intrude the premolars and molars significantly. We'd also like to extrude the upper left lateral and the upper left canine, and maybe still have a bit of intrusion in the upper right lateral and upper right canine too. So let's go back to our plan and look at our final position here. So at the end of treatment, have these teeth intruded? They have. The premolars and molars are going up. Is our lateral and our canine extruding? Not a tremendous amount, mostly just derotating. So those could come down and these teeth could come up. And we may want to consider doing more intrusion than what's shown. Something that's really important to know is anytime you're moving teeth through bone, it's a harder movement. So you need more forces in order to make those movements occur. Or in some cases, the movement through bone is so challenging that you can't even accomplish it with braces or aligners. And that's obviously this case, that's why we're using TADs. So is there a can't? Yes. Do we need to make adjustments on that? Yes, we need to go ahead and we need to probably intrude those teeth a little bit more even. Is there a midline shift needed? So let's go back to the patient's smile. Now, everybody's going to have some facial asymmetry. It does look like her midline is deviated more to her left. So if we look at the middle of her nose down to her philtrum right here, and then we look at the middle of the teeth, her dental midline is to the patient's left, ever so slightly. Now, midlines can be shifted up to 4 millimeters without a negative, without a layperson being able to recognize that. But it is something that we can make some improvements on. Now, one of the things in the prescription form that I realized is I had noticed that her midline was shifted to her left. So Kant's, yes, we need to adjust that a little bit more. Midline adjustment needed. And so is it either shifting when it shouldn't, or does the midline need to be moved? So it's not shifting, well, I guess we can look at it first. Is it shifting the wrong way? No, it's actually moving to the patient's right. Now, why is it moving to the patient's right? Well, because we actually planned some IPR. We asked the technicians to place IPR in quad 1 so that the midline would be able to shift into the space that we created when we do some IPR. We did a little bit of IPR on the lower, planned it at least, so we could move the midline on the lower over and have more coincidental midlines. So is a midline adjustment needed? Yes. Do we have it? Yeah. So thanks, Stephen from the past, for realizing this when we filled out the prescription form. Okay, what's next? Bolton, restorative, and IPR. So does Bolton matter? So first of all, what is Bolton? The Bolton is an analysis that you can see here by clicking on the Bolton tab, which is going to show us if there's an excess of tooth structure, either on the upper arch or the lower arch, comparing how they fit together. Right? The Bolton is essentially how a lid and the box come together, the maxilla and the mandible. If the box is too big or the lid is too small, the patient will often hit edge to edge, and that will cause a posterior open bite. Because it's like trying to fit a Tupperware lid on the wrong size Tupperware. You're jamming it on, and then it's popping off in another area. And so if there's a Bolton discrepancy, we either need to make the box smaller or make the lid larger. That's really your two main options, assuming this patient doesn't have a giant overjet. So is there a Bolton? So first of all, actually, the question is, does Bolton matter? So Bolton matters when the patient is in class 1 or class 3. Those are when it's the most relevant. Now, is this patient class 1 or class 3? Yes, they are class 1. So does Bolton matter? Yes. If they were class 2 and had a large overjet at the final stage, Bolton would not be important. It would not matter at all. Who cares? Okay, so if Bolton is important to pay attention to, then we go to the Bolton table. And so the Bolton table shows us that we actually have a slight maxillary excess. Now, having a maxillary excess is actually better than having a mandibular excess, because a maxillary excess just means that the lid is a little bit bigger than it should be. That's better than having the box being bigger. So it's actually okay that we have a small maxillary excess in this circumstance of 0.7 millimeters between the canine to canine region, or about 1 millimeter between the first molars. Now, a Bolton really only becomes relevant when the Bolton is going to be more than 2 millimeters. So let's say you had a mandibular excess right here, and the number it gave you was 1 millimeter. Who cares? Doesn't matter. It's not clinically relevant. It's only if it's 2 millimeters or more for a Bolton discrepancy, either canine to canine or first molar to first molar, that a Bolton needs to be changed by doing IPR or by doing restorative. So with all of this being said, now that we know the Bolton is not needing to be adjusted, it's not 2 millimeters or greater as shown here, so it doesn't matter. Is the upper lateral incisor less than 6.4 millimeters? This was something that Dr. Terry Coddington taught me, which is a great pearl, is that if a tooth is less than 6.4 millimeters, I mean, not really a pearl as much as just common knowledge that I should know, but Terry was really the one to put this number into my mind, 6.4 millimeters. So credit goes to Dr. Coddington for that, because it's just a good guideline of whether a tooth might be too small. It's not. Okay, next considerations would be, is there fragile tissue with severe crowding? So are we worried that if we don't do IPR here, we're gonna get recession? So is there a lot of crowding? No, not a lot. But let's go ahead and actually look at the patient's intraoral photos so we can see how good does their biotype look. And you see here that the biotype is actually great. These gingiva here are really, really thick and juicy on the bottom. So I'm not really worried about recession occurring. Hygiene can definitely be improved on, and always check to see if there's calculus gluing the teeth together. But all in all, I'm not too worried about the biotype of the gingiva, and so that's great. So we don't need IPR for fragile tissue in combination with severe crowding. The next thing would be black triangles. Will there be black triangles that could open up during treatment? Now, a good rule of thumb here is that anywhere that you have really crowded teeth, like between this lateral and this canine, you're going to see black triangles. It's just the fact that the gingiva has been compressed, and as you move these teeth, it will result in, let me just put the upper arch, it will result in a black triangle, and the ClinCheck actually does an exceptional job of showing you those black triangles. It does a really, really good job of kind of predicting where they're gonna be in adults. Black triangles in kids, don't worry about it. It does not matter, it is not relevant. There will not be black triangles because their gingiva will come back up. Or down, I guess. But don't worry about it in kids. But in adults, this is something we may want to be aware of, that this patient may either bring this up to us later, or we might need to address it later. A good friend, Richard Schmidt, he's been showing lots of cases where give it 6 months and the gingiva actually will start to come down again. So I don't do as much IPR for black triangles as I used to a few years ago. Now I often do give it a chance for 6 months to see if it will get better, and then if it doesn't, we can always jump in with some IPR or some bonding. Same thing on the bottom here. As we derotate these lower incisors, you will see a black triangle here. So if IPR is needed in that area, again, no biggie, not too worried about it. I'm not going to talk about my IPR methods in this particular lecture, but the IPR method that we use is so seamless, so easy, so quick. It's using a Strauss burr. It's phenomenal. Number of people who've texted me saying it's changed their Invisalign life is significant. Okay, so black triangles. Do we have them? Yes. Are we going to do anything about them right now? Probably not. But you could go ahead and put some IPR in those areas if you wanted to. Okay, next thing is going to be anterior worn teeth, uneven gingiva. So as we look at the teeth, do we want to level the gingival margins or the incisal margins? I mean, she does have some wear in this case, but in her particular case, I can tell you in advance here, we did not actually do any restorative, but you could consider it. I mean, there is wear, and the width of the teeth and the length of the teeth is starting to get out of sync because of that grinding. But it's just the consideration of, do you level the gingiva or not? Okay, is there enough overjet? So do we have, I don't, by the way, usually look at the table here, but you could, but do you have 2 to 2.5 millimeters of overjet at the end of treatment? Yep. I usually just clinically look at it and say, like, does it look like there's enough overjet there? Or does it look like the anterior teeth are gonna smash into each other? But yes, we do have enough overjet. So I'm happy. Okay, next, IPR occurring when contacts are open. Okay, let's check it out. On our upper, I want to make sure that the teeth are derotated before IPR occurs. Because if we do IPR at aligner number 1 here, we're actually going to be doing more IPR off of the buccal of the tooth compared to the actual interproximal contact. So let me show you. right? If you're doing IPR right now, where it's going to occur, you're kind of coming in from this angle or maybe this angle here, but either way, you're doing more off of the buccal surface of the tooth, right here, and more off of the lingual surface here, whereas the actual area that you want to be doing the IPR to reduce the mesial distal width is right here and right here. So you're not doing the interproximal reduction on the right surfaces to actually decrease the width of those teeth. And it can result in the teeth looking very, very funny if you're doing the IPR on the buccal of a tooth and the lingual of another tooth. So in very few circumstances do we do IPR when there's crowding between teeth. Instead, we'll almost always derotate the teeth first, and then the IPR can occur once the teeth have moved into a proper position. So they've waited a little long, to be honest here. Oh, just make sure we're on the right screen. We are. They've waited a little long because I think they can do this IPR probably at like aligner number 30 now. The contacts are fine, but they've placed it at 36, which is fine. It's not the end of the world, but the main thing is that the contacts are derotated. Same thing on the lower. Let's check it out. Are the contacts derotating first before the IPR occurs? Everything derotates, derotates, derotates. Again, they kind of wait a bit long and then they do it, which is fine. And then it's finished. Sweet. So the contacts are open. And are they fully derotated? And is there going to be a recession risk if we do that? Well, we checked the gingiva already. There won't be. We could probably go ahead and say, please do IPR all at aligner 30, which would just get it going a little bit faster. Okay, are we leaving restorative spaces? We are not. Okay, let's say that they did not give you the proper IPR here. This is just, you can copy and paste this exact sentence. Complete IPR once contacts are nearly derotated. Ensure all IPR occurs at the same stage. That's the phrasing that I use because if you say fully derotated, they'll always give you a bunch of extra trays that you don't need. Whereas if you say nearly derotated, then they'll usually be more efficient and not kind of give you 70 aligners and then finally derotate the teeth by like 68. Okay. Now, I know that right now as we're going through this, some of you, if you're newer doctors, might be saying like, well, Stephen, this is a lot of things you're going through. Like, you look at all of these on every single ClinCheck? Yeah, I do. The reality is all of these little itty bitty tiny decisions take like 3 seconds. Are they doing IPR when the contacts have finished straightening? Yes. Is the IPR occurring at the same time, so on the same stage between all of them? Yes. Next. Right? It's not like it's this big, huge decision of does this giant ClinCheck look good? Instead, it's like, hey, let's break this up step by step, and then that will help guide us as to what we need to change. Even if it's a TAD case or a complicated case, it's the same exact process every single time. And so I'll hear doctors sometimes say, well, I don't want to use your checklist because I don't want to spend the time to go through it. And it's like, okay, to each their own, but like it's designed and set up to make things easier for you and to allow you to take on harder cases long term. And whether it's my checklist or somebody else's, the main goal is just have a system that you approach the same way, the ClinChecks the same way every single time. And when you're actually doing these, sorry, last thing is when you're doing these, I can do any ClinCheck in probably less than 5 minutes. Hands down, like any ClinCheck, 5 minutes, no problem. And it's not because I'm super smart. It's not because I've been doing this for 30 years. It's because we have a systemized approach to how we do it. So it's just like decision, 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 decision. And then it's like, okay, this is what we're left that we need to adjust. But it takes a bit more time when you're first doing your first ever ClinChecks because you do have to take some time to go through it. So it might take you 40 minutes to go through a ClinCheck when you're doing this for the very first time. But that's okay because you'll get faster and you'll get better with it. But it's the way that you make improvements. So I'm going to copy this. Please do all IPR at line number 30. Oh, let's go back there. Control V. So that's something that, again, I can't do. The technicians have to do that. Intrude more. Staging. Okay, is round tripping present? So what does the round tripping present mean? That means that our teeth moving one direction, then moving back the other direction for no reason. So is there a purpose for it? Well, you can see here that we said, yes, the teeth all kind of procline and then they straighten the line and then the IPR occurs and they move back into that space that was created. So that is round tripping, where teeth move one direction, right? They go buccally. And after they move buccally, IPR is going to happen and then they're going to close that space. This is round tripping that I'm okay with. It's all right that the teeth are moving one direction and then moving another direction, because we want to first derotate the teeth and make sure we don't have tight contacts between them. That's one of the main reasons that teeth don't move, is they're hitting up against each other. So a really crowded or rotated tooth, it can actually be a good strategy to tell the technician to leave a little bit of space around that tooth as it derotates. I'll show you here. The instructions I actually gave to the technician here was, do not allow tooth collisions during movement. Create and maintain a 0.1 millimeter of space around the upper 2-2 at all times during treatment. So around this upper lateral, because it's a hard movement, I've specifically asked them create space around it so no friction happens until the IPR occurs, and then they can close the space. Right? It makes sure that this is going to track and work properly. So round tripping is present. Are we going to remove it? No, it's fine. Next one, extrusion predictability. Is anything extruding here that requires an elastic to help pull it down or anything like that? Well, no, not on our anteriors, but what about these guys? We're talking about how we're going to intrude all these upper teeth in quad 1. Well, all the lowers are all extruding. Every single one of them is extruding. And they each have big boy roots on them. 2 roots on the molars, single roots on the premolars that aren't short. That's a lot of root to move. So are we going to be able to do this alone with aligners? You already know the answer. Absolutely not. So do we need to consider using something else to help them extrude? Well, yeah. What's that going to be? Well, let's go through our checklist. Okay. Is the staging good or bad? Well, the staging is fine. It's showing those teeth just directly extruding because we know that's what we're going to be doing. We're going to plan to extrude all those teeth together. It's just how are we going to do it is going to be the way that we figured out. So again, even if you weren't doing TADS on this case, if you were just designing everything we've said so far, we looked at the smile, we looked at the midlines, we looked at everything that's going on, you would end up in this exact same spot saying, well, crap, in order to fix this cant, I need to intrude those posterior teeth. Well, if I'm going to intrude the posterior teeth on the upper, if I need to have occlusion at the end, that was my first checklist item there, was what's the bite look like at the end, I need to extrude the lowers then. Well, if I need to extrude the lowers, is the extrusion staging good or bad? Well, it's pure extrusion. Well, is any attachment going to help me with that? No, it's not. There's no attachment that can help you extrude every single teeth in the entire quadrant to that degree. So is the attachments, are they good? Well, no, not really, because we can't do this with attachments. Okay, well, are we needing to use some vertical elastics? So elastics that will hook on to the bottom and pull up to the TAD. Yes, there is. We need to use those elastics. So yes. Okay. The next one would be, is there adequate space around a tooth if it's blocked out, if it's just a single tooth? Well, not really our situation here, but a good point again, just always remember, if a tooth is moving, and it's moving a lot, consider having space around it, like we previously mentioned. Okay, next thing, the amount of trays. Is the amount of trays okay? Well, how many trays do we have in this plan? We have 40. Is 40 trays with weekly changes going to be enough? Well, 40 trays being 40 weeks, means that we're looking at what, 9 months, 10 months? I think that's all right for our first batch, so I think we're okay. But if they had given me only 12 trays here and said that that was enough to accomplish this, I'd say, like, no, I need way more trays. And if they gave me 100 trays, I'd say, well, do I really need at 1 week per tray? That's 2 years. Is 2 years needed for this? No, that's overkill too. So like, is 10 months reasonable for the first round of trays? Yeah, totally. Okay, cool. Hopefully you guys aren't too bored. Next, again, this is so easy, guys. All we're literally doing is we break this into a million little decisions, and it's like, do this, do that, do this, do that. Like, this is not rocket science. You don't solve a Rubik's Cube by looking at it and being like, this is exactly what I do. You look at the algorithm, you turn it, and then you go to the next one, you turn it, you keep turning it until you finally come up with your completed design following a set of rules and instructions. It's the exact same thing. Okay, so Pontic's interruption compensation. Is this patient missing any teeth? Negatory, nothing. It's all there. So the entire Pontic's eruption compensation section goes bye-bye. All right, what's next? Attachments. So are there any attachments on crowns? There's not. We already looked at our pan earlier. Next thing, is there retention attachments required where we need to use them, either moving them around or increasing their thickness for deep bite correction? Well, we did talk about that briefly, that yes, we do need to go ahead and intrude these lower incisors. So we may want to change out some of the attachments on the lower premolars. Those are the teeth that help lock in the attachments when we're working on our lower molars. Now, unfortunately, I can't actually make all of the changes for these attachments right now because this is a completed plan. It won't let me modify version 1 of this plan. I've actually been telling Align for a really, really long time as a lecturer. Their old software, the downloaded desktop version, allowed me to actually export this plan and make all the changes and corrections right then and there. I really wish that they allowed me to do that with this software on the online version because I want to now modify this to show you, but instead I'm gonna have to show you just on a kind of a different plan. I'll show you how I do it in a moment here, but I wish I could do it differently. So yes, we do want some new attachments that we might use for the deep bite correction on the lower premolar. Are we expanding a lot? No. We kind of talked about how our arch form is pretty good. We don't need to expand a lot. Are we moving our upper lateral incisors? Yes. Do we like the attachments on our upper lateral incisors? I don't love them. The fact that we have attachments on the upper lateral incisors is good, but I don't love the attachments. I'd like to reorient those attachments into a sash orientation for more of rotation of the tooth. So I'll leave that and we'll adjust it as well. Okay, last thing, root rotations and difficult movements. So of the teeth here, I'm not even gonna go ahead and show the tooth movement table or anything else. I just want you to look at this ClinCheck right now and I want you to tell me what teeth, don't even look at the attachments. Don't look at the IPR. Just look at the teeth. What teeth are the most crooked and have the biggest movements that need to happen? It's not rocket science. Lateral incisor. Lower first premolar. Those are the teeth that have the biggest movements that are happening, where the roots of the teeth are also going to have to move the most. And so those are the teeth that we should consider having particular attachments on them that might be different that we're adjusting. So I'm going to say here it's going to be the 4, 4. We're going to put a vertical. Now we might also want to have that button cut out too. But I'll show you how we make this adjustment in a second. So 4, 4 vertical. And then on the upper lateral incisor, that's the 2, 2 sash. Okay, cool. So elastics. Do we need them? Yes, we need them to help extrude and intrude the teeth in quad 1 and extrude the teeth in quad 4. Anterior posterior, do we need them for that? And actually, let me just leave that here. So anterior posterior, no. Crossbite, no. Vertical, yes. AP correction, nope. Okay, and then are they going to be in the proper location? Well, we don't have them right now, so I need to move them all in the right spot. Okay, so here's everything that I'm left with that I need to adjust to give myself a great treatment plan. Now again, unfortunately, I can't just click the modify plan on this plan. I have to do it on a different one. So I'm just gonna actually go to treatment plan number 9, which is like their completed treatment plan when everything is all said and done. I'm gonna click modify on that. You guys missed that because I'm not showing the full screen. But I clicked modify on the top right, and now it'll let me go ahead and make some changes. So I'm just gonna show you real quick how you take control of this using 3D controls yourself. Now, everything here at the end is pretty much all perfectly set up right, but I would be able to grab using the tooth feature here, these anterior teeth for our curve of SPE, and I can go ahead and I can intrude them more. I'm just pushing them down into the bone a little bit more. I can extrude those premolars. So if I'm doing a bit of a reverse curve of SPE, I might show something that looks like this on our plan that just shows the anterior teeth more intruded than not. It's over intruded. So that's how you would over treat the curve of SPE. The cants, well, if I want to go in here and I want to intrude these teeth even more, I can go ahead and select them all. And here's a little tip, how you can click multiple teeth as you hold down the control button. So I'm holding down control and that lets me select multiple teeth. And I could do something like this. I can grab all of these teeth and just intrude them more. Cool. If I want to intrude the lowers, grab these teeth and intrude them again, or extrude them. Now please know again that this is not occurring because we are intruding those teeth with aligners. It's not going to happen. It's from the TADs. Okay, let's say I need vertical elastics now on these teeth. I can just click on the features button, drag over my elastics, right, this little guy right here, the button. Drag it onto all of my lower teeth. And now I have button cutouts to hook on my elastics. So that's my vertical elastics. I need attachments changed on my lower premolars. So the attachments we like to use are nice, thick, horizontal, 3 to 4 millimeter rectangle attachments. Grab them, pull them to their maximum thickness, easy peasy. That's gonna help with the intrusion of those anterior teeth because the plastic is pushing down from the incisal edge on these anterior teeth to intrude them. We need somewhere to act as our anchorage to lock in place. Now, if we can, ideally, we'd actually even go ahead and place some of these attachments. Now they're more restrictive with where we can place them, but we could actually go ahead and do the same. Even though we're extruding all these anterior teeth, we could try and go ahead and place some horizontal attachments here to help with the deep bite intrusion as well. Now notice I did not place one on the 4-4. That's because we can still go ahead and place a vertical attachment to help work on our mesial distal root. Again, it won't show it here, but the mesial distal root position. So that was the 4-4. So our upper lateral incisor on the 2-2, we wanted to place a sash attachment. That's this guy. We'll click it to 4 millimeters. We move it so it's at a 45-degree angle. All right, 45-degree angle. And now we can grab this and we bevel it, we drag it towards the gingiva. There we go. So now this is the pushing surface coming from the gingival. Again, I'm not going to go into the attachments component too much. If you have more interest in that, then check out attachments and biomechanics or join Clearly Select and you'll get access to attachments and biomechanics, as well as all of the in-person lectures that we do and everything else. But essentially now those were all the changes that I just made in 3D so that we can make it ourselves. And the only thing that's left for the technicians at this point is 2 instructions. And those instructions are, give us 4 nearly passive trays at the end of treatment. And please do all of the IPR at aligner number 30. The beautiful thing about this setup is the fact that the technicians now literally, I don't want to say can't screw it up, but like there's not a whole lot that they can do wrong because we just took control ourselves. So let's look at the plan, and then I'm going to show you how we place the TADs. I'll also show you then how things actually look. And you can see I didn't necessarily do everything exactly the same as what was shown here. Some of the things change over time, but so here's plan 6. So what did I do? I placed my lower buttons. I placed a that vertical attachment for the root rotation. I didn't actually change out the attachment here on the second premolar for the deep bite correction. And I actually even left this one as a vertical. I'd change that nowadays, but I also don't want you to get so much paralysis here, being like, wow, Stephen made 55 different decisions there. And I would have only gotten maybe, some people might be like none. Hopefully now you'll get a lot more. But some people might say, hey, I would have only gotten like 35 of those decisions. That's okay. You'll see on my old ClinChecks like this was 2018. I do lots of things in this plan that I would change now, that I would make better. You don't have to be perfect right from the start. And for perspective, I did this case when I was less than 1 year into doing my Invisalign treatment. This was 2018, August 1st. So I had done less than like 100, whatever, like less than 200 cases at this point. Like this was one of my first cases. And so I just want you to see that don't get paralysis by analysis. You can do things that are not going to be right and it's still fine. Okay, so there's the sash attachment on the lateral to help rotate that tooth. In the posterior here, we're intruding these teeth, and you can see how I changed the intrusion. I overdid that intrusion. We've got a lot of intrusion on the upper and a lot of extrusion on the lower. If you were to click right now on our tooth movement assessment, check it out. Shulk, you're crazy. You have all black dots. Like, what are you doing? I've heard before that you should never have any blue or black dots. Try to minimize them. And here I am being the opposite, being like blue and black dots. Like, who cares? It doesn't mean anything to me because blue and black dots just mean that we're planning the trays to move and push against the teeth more, but it doesn't necessarily mean that's what's going to happen to the teeth. If everything happened the way you planned it on your ClinChecks, you wouldn't need me right now. You wouldn't need TADs either. You would just accept your plan and you'd call it a day and it would work and it'd be perfect. But that's not how it works. And so do not, in my opinion, be scared of black or blue dots. It means that, yes, we're pushing against those teeth more, but it doesn't mean that it's not going to work or that it's inconsistent even at working. It just means you have to know what steps you need to take to ensure that this is going to track properly and to do what you're wanting it to do. And again, the entire attachments and biomechanics course is just designed on how to take control of your own plans and understand which attachment should go where and why. And then you won't ever worry about blue or black dots ever again because it will all make sense. So here's our plan, right? We kept it at 40-ish trays. Our last trays here, they're all passive, so nothing's changing or moving. Pretty easy setup. Okay, so where are we placing the TAD? So we know we need intrusion in quad 1 and quad 4. For all the Americans that are on the call, I do not know those teeth numbers, so you have to learn the Canadian system. Quad 1, quad 4, those teeth are intruding and extruding. So where do we need to place the TAD? Well, we need to go ahead and place the TAD into the buccal shelf, or the buccal of the upper. And in this case, we're just placing it right between the two roots. And on the palatal, we're just, again, going to be placing it right between the two roots. And the elastic then is going to hook on over top. I don't know if you can see it here, but it's hooking on after the tray goes in. So the tray gets put in, easy peasy, just like normal. Then the patient takes the elastic, hooks the elastic rubber band over top of the two TADs, and that pushes up against the tray to intrude those teeth. That's it. Then on the lower, well, we need to extrude those teeth. What we're going to do is the patient's going to wear an elastic at nighttime, and the elastic's going to hook from their TAD down to those lower buttons to help extrude those teeth. So they're wearing their TAD on the upper all the time, 24 hours or all the time throughout the day. And then at nighttime, they're switching out and they're wearing an elastic from their lowers up to that upper TAD. So this is how we're hooking on the elastics for that patient. And so the elastic's what's actually doing all the work for us, right? Another series of photos just showing partway through treatment. This is mid-progress. You can see how that lateral incisor has started to rotate nicely. Here's the elastic hooking on again. Now it's important to know that this patient needs to change the elastics 5 to 7 times a day. So when they wake up in the morning, new elastics. At breakfast, at lunch, if they have a snack in the afternoon, at dinner, before they go to bed. Every time that they're taking their trays in or out, a new elastic goes in. The size of the elastic is going to be a 4.5 ounce, 3/16 inch. So 3.316 inch, 4.5 ounce. Again, I'd love to go through an elastics breakdown right now, but to show kind of everything we've going on right now, we just don't have the time. But in my in-person courses, I go through it very frequently. Again, for those joining Clearly Select, you get access to that recording that you saw there. That was either Calgary or Vancouver. And I go through comprehensively how elastics work. And I also teach about that in Clearly Select, just in the different courses, as well as in the WhatsApp chat. Essentially, all that's happening then is the elastic just slowly over time is pushing up on those teeth and intruding them little by little by little. And you notice we actually start getting a little bit of a posterior open bite, which is fine because we just need to finish extruding those lowers after that. So what you're going to notice when this patient comes back for a refinement, let me go back to here. So here's her initial. This is 6 months. The TADs can actually move teeth quite quickly, relatively speaking. Now we're at refinement. So what do we do at refinement? Well, it's pretty easy. All we're going to do at refinement is we're just going to go ahead and get more trays that are going to push those teeth up. So here's treatment plan number 8. We've got some extrusion occurring on those lower premolars and molars. The TAD is still hooking on though, from the TAD to the TAD on the buccal and the palatal and intruding those teeth. So it's not just going to happen like the ClinCheck shows here where the uppers aren't going to intrude anymore. There will still be more intrusion occurring. And don't worry, guys, I haven't forgotten about showing how to place the TAD. That's still coming. So we just get another plan, but for the most part, all we're doing is I don't really care as much now about the movements. Like everything's pretty straight. Maybe the lateral needs to tweak and that lower premolar needs to rotate a bit more. No biggie. And we just do that with our new round of aligners. But what I care about the most is, again, getting those elastics to push up against the occlusal surface and continuing to intrude those uppers because on our plan, we're not there yet. She's still not quite happy. So that's the plan that you just saw. So we go ahead and we just keep using the elastics and intruding. So here's where we're at then later on, and she comes back again. And this is the one that I clicked modify on, so I'll go back. But here's where she's at on her next batch. Right, so in this case, I didn't even actually get any trays. Now, you can't do this nowadays, but I didn't even get any trays to show more intrusion in the back. And actually, it would have been, I guess, still maybe on this one. But we just kept intruding these teeth more and more with more trays. Because just with more intrusion of the elastics, that gets her to the point now that her bite's looking really good. And then at this point right here is where she's made the decision. And I normally just let the patient make the call on this. I asked her, are you happy? Do you want this to keep going any further, or are you good? And she says, no, I'm really happy. So we go ahead, we take out the TADs, and we're done. Now the TAD, you can see this is where it was. This is the same day. This is like 5 minutes after the TAD came out. Literally all you're doing to take out that TAD is I don't even use freezing because it takes more time and effort and energy and more discomfort to freeze them than literally we put sometimes some topical around it. And I just tell them, look, it's going to feel about the same as getting a needle. You untwist it, and it's super, super easy. It's super fast. Same thing on the palatal side here, no freezing or anything like that. Just literally unscrew it out, and that's that. It's not that hard. I guess, again, the goal is not, I don't want this to be an infomercial. I don't like selling things. I don't think that I do sell Invisalign when I am talking to patients about it. I think that Invisalign makes sense because it's going to improve the patient's bite, their function, their health, and ultimately their life. I think joining Clearly Select is not me right now selling anybody on anything. I think that it's me discussing the goals of what I'm trying to do with my life to help make a difference in a bigger impact. I know that I could see about 400, 500 patients a year, but since 2020 when I started lecturing, I've lectured now to over 3,500 dentists. If you assume that each one of these dentists has 1,000 patients, you're looking at 3.5 million patients potentially impacted from what I've been able to share with doctors. There's 300 million people in the States. That means that every one doctor, if this was just the States, every one patient in 100 has gone to a doctor then that's been a clearly aligned, educated doctor. Like, that's amazing. And so the things that I want to provide to a more in-depth group is, I feel like just providing courses isn't enough because you don't get that continued support. So there's really 5 things we're looking to accomplish. Number 1 is knowledge. You need to have information and education in terms of how to actually do this, right? What you're doing right now, giving up your evening to sit there and listen to me go on, right? And so we have over 180 hours worth of education available in so many different topics, whether you're a brand new provider or whether you're very experienced. We've got the entire library of everything clearly aligned related is available to you, and much more that's only available to Select because that's now kind of my baby, my focus. That's number 1. Number 2 is I want to give you confidence, right? And give you support with designing and planning cases, just like we're doing right now. Our team designs and creates ClinChecks for you to help push you outside your comfort zone and take on cases that you otherwise wouldn't, but knowing that you have experts that are going to help design it for you and keep you in the guardrails. Even from this alone, the goal would be is that you're taking on 10 cases you otherwise would have referred or not treated. Even at whatever, call it $5,000 per case, that's an extra $50,000 worth of revenue coming into your practice if you're able to do that. So we provide, I would like to say, the most comprehensive ClinCheck reviews in the industry because we like to talk. Number 3, community, right? We've got a world-class group of dentists who focus on orthodontics, but also in other areas. It's amazing seeing the different speakers that are available in pediatric airway and restorative, in other things that support aligners or even are separate from aligners entirely. But I think the quality of what we're trying to accomplish attracts other really quality individuals. And so the quality of the community is very, very high in terms of the goals of what people are trying to accomplish. The next one would be logistics and profitability. So you could have all the knowledge but not know how to implement it. So we give you access to all of our forms, our scripts, our checklists, the new patient videos that we create, dental monitoring support, everything that you need to be profitable, but also we give significant discounts to doctors. We have to have doctors go through a non-disclosure agreement. You have to sign it. It's just the reality because we cannot share some of these discounts without having an NDA signed. It's just we have specific contracts in place that require that. But I can guarantee you that you will be saving on average $25,000 or more based on lab fees for aligners as well as other products. So there's a significant savings that comes from our purchasing power because the volume that our doctors are doing is significant. And then the last thing is accountability. And I'd like to say this, that we didn't become, I always say we because it's my team, but I guess I didn't become the world's youngest diamond provider as a GP by being a pushover. Like, I'm going to tell it to you straight. I'm going to make you set goals. We're going to track to help you accomplish the goals that you set for yourself, right? We have an expectation of growth and learning. It's nothing crazy, but it's not that everybody is going to fit into this group because there is expectations about being committed to learning and to becoming better at what you do. My promise and guarantee is that I'm super committed to helping you grow your Invisalign practice and take control of your lifestyle to be able to do what you want to do Like again, for me, I work 1 week per month and I make as much money as I did when I was an associate working full time, right? Or not an associate, but when I was an owner doing all the general dentistry, right? There's ways that you can make this so extremely profitable and enjoyable, and you're giving back and doing really fun, interesting things where you use your brain. So honestly, guys, if you're not doing a high level of Invisalign right now, what are the chances you're going to do it later in your career? So why wait? Learn now and take advantage of more time that you can make more money and really feel passion over what you're doing.